Hello again, and we are picking up with the second part of the Chapter 22 lecture. This will be for Session 4. We're picking up where we left off in the respiratory system physiology. In talking about oxygen transport, the good news is that oxygen transport is fairly straightforward, especially when you compare it to carbon dioxide. Carbon dioxide reacts with water to form carbonic acid. Oxygen just isn't very soluble. And so, how vertebrates have solved this problem is with a molecule known as hemoglobin, which is part protein. So, we have four individual chains, two alphas and two betas. And embedded in those chains is this thing called a heme molecule. Heme is a combination of what's called a porphyrin ring. It's a ring of carbon and nitrogen that basically serves as a cage for iron. Transition metals like copper or zinc or iron are very, very reactive. And so iron is incredibly reactive. And it'll actually react with oxygen spontaneously and form rust, right? So it's very reactive. So in order to prevent it from causing damage to cells, vertebrates have developed this cage in order to kind of keep iron in its place, and that's the heme ring. And what happens is that the iron will solubilize oxygen, and when it's holding as much oxygen as it can, it is what we call saturated. And so, roughly around 100 millimeters of mercury, and I've discussed this in class, that pressure is synonymous with concentration. So, if we get about 100 millimeters of mercury oxygen pressure in and around in the lungs, that will saturate the heme rings of a hemoglobin. All right. Now, there is oxygen even in deoxygenated blood. So if around 100 millimeters of mercury saturate, it turns out that when venous blood comes back, it's still at about 40. So there's a little bit of oxygen left over, even though the hemoglobin isn't fully saturated. And that's known as the venous reserve of oxygen. Now, when oxygen binds hemoglobin, we call it oxyhemoglobin. And when there is reduced, when it is unsaturated, sometimes people will refer to it as deoxyhemoglobin. Oxygen isn't the only game in town. In fact, there are other molecules, most notably carbon monoxide. Carbon monoxide is actually a flammable gas. They used to use it to light homes. They actually used to pump carbon monoxide into homes, and it would burn just like like methane gas that we use or propane. And so that's what we used to light houses. And as such, doing that meant that if there was any extra carbon monoxide around, people would typically suffer from carbon monoxide poisoning, because carbon monoxide has a higher affinity to hemoglobin than oxygen, and it will actually knock oxygen off of the heme. By maintaining ventilation and perfusion, we get gas exchange. So we inspire air at a given pressure, and by the time it reaches the alveolus, we have about 100 millimeters of mercury, 40 millimeters of carbon dioxide, which is a little lower than the blood coming in. The blood has a little more CO2 and a little less oxygen, so we get exchange. Now we have oxygenated blood goes out into the tissues, and then the tissue, the oxygen's a little bit lower, so we give off oxygen. CO2 is a little bit higher, so we take on CO2 and repeat the cycle. So it's just showing here. So by the time we inspire this air, you can see we're about 160. That's about 20% of the overall pressure. We get into the alveolar space, there's a little more CO2 there, and so the partial pressure drops. And again, right around 100 is what we want. We give off the CO2 because there's more CO2 inside the blood than in the airspace, and there it goes. And then a little more oxygen than in the blood, and it switches out that way. So PO2 is the key thing here. Again, you do have some competition for O2 sites. What we see is that as we increase oxygen, we get more binding. That should make sense up to the time we saturate. And if we have less partial pressure of oxygen in the environment, that's the blood plasma, the hemoglobin will give it off, again, moving towards what we call equilibration. Now, the thing that's a little technical about hemoglobin, but is important because it justifies why we will do things like ventilate patients, or we might add oxygen to their mouths or nose in order for them to increase percentage of oxygen, is that hemoglobin will saturate at or around 100 millimeters of mercury. And that's why that number is so important. And we're talking about in generally standard conditions, but hemoglobin isn't always in standard conditions. And so when it departs from those conditions, or if there's less oxygen, we see less saturation. This phenomenon of what we call dissociation is the reason why you can do a pulse oximeter. You can put a little doodad on somebody's finger. It can look at the color of the blood and determine how saturated it is. So normally at 100 millimeters of mercury, we'll run around 98, 99%. If we get down to 40 millimeters of mercury, what we see is we're somewhere around 75%, okay, somewhere in there. So, we shift under normal circumstances between the tissues and the lungs somewhere around 25% saturation. If we get lower than that, then we'll give off more oxygen and so forth. So this is called a dissociation curve. Under what we would call normal, that is to say a pH of 7.4, 98.6 degrees Fahrenheit, 37 Celsius, and standard, pressures and so forth. This is how hemoglobin will behave given the amount of, or the concentration of oxygen in the blood plasma. If we hit about 100 millimeters of mercury, like we do in the alveoli, our saturation is somewhere around 98, 99%. And when we get out into the cells, that percentage drops down to about 75%. That difference has been oxygen that's given off. So when we out in the tissues, we're going to be giving off oxygen. When we get to the lungs, we're going to be taking it on. That's your normal dissociation curve. But what happens when things start to change? Well, when things start to change, this curve shifts. For instance, it could shift to the right or it could shift to the left. And there are reasons why that curve will shift. And let's look at them. Another way of putting it is if that curve shifts to the right, like this one right here, that means it requires more oxygen to saturate the sites on hemoglobin. So 100 millimeters of mercury on this particular curve would only get us to about the level that normally 40 would. And if we're at 40, you can see that we're fully halfway completely disassociated. So we're going to need a lot more oxygen in order to get us up to that saturation level. Well, what would cause the curve to shift to the right? On the other hand, if the curve shifts to the left, it requires less oxygen. We're saturating at about 60 when we shift to the left. So again, much less oxygen required to reach saturation. Now that seems great. Like, why don't we just make the hemoglobin, have more affinity? Well, if it has more affinity like this, it won't give off that oxygen in the places that we need it to. All right. So we want the curve to shift to the right when we want the hemoglobin to give up oxygen, and we want the curve to shift to the left when we want the hemoglobin to be binding oxygen, like in the lungs. Okay. And so back to our original slide here. What would cause the curve to shift to the right? Well, there's one thing called the Haldane effect, and that has to do with the fact that carbon dioxide competes a little bit. It's a mild competitor for oxygen. If we have elevated CO2, that will cause the curve to shift to the right, and then the hemoglobin will give off oxygen. That happens when we get out in the tissues. So in the tissues, we see a higher concentration of CO2. That means that the hemoglobin will have a little less affinity for oxygen. The same thing is true with acidity, and that's known as the Bohr effect. All right, the Bohr effect is that pH affects the affinity of hemoglobin. And when we have a lower pH, again, like out in the tissues, that will cause the curve to shift to the right, which means that it will facilitate giving off oxygen. Increased temperature is another thing. And again, temperature in the tissues is higher than in the lungs. Cause a right-hand shift, give off oxygen. You can see a trend here. When we get into the tissues, we tend to have elevated CO2, lower pH, and increased temperature, all of which will contribute to the hemoglobin giving off oxygen. Now, when we're in the lungs, there's less CO2. That would cause the lungs to have, or the hemoglobin to have more affinity. We're generally a higher pH number, which is less H. So we're a higher pH, and we're a lower temperature. Your lung temperature is a little bit lower because you're breathing in atmospheric air. So less CO2, higher pH, lower temperature, all shift the curve to the left. Higher CO2, lower pH, higher temps, all cause the curve to shift to the right. And the last thing is this 2,3-DPG. It's a little bit of a funky little molecule. When red blood cells are exposed to low oxygen concentrations, they'll begin hydrolyzing glucose, and that creates this 2,3-bisphosphoglycerate. We just abbreviated either BPG or DPG, either way, bi or diphosphoglycerate. When that goes up inside the red blood cell, that means that it will cause the hemoglobin to want to give off oxygen. And if we have it low, it will cause a higher affinity for oxygen. This is particularly true with blood bank blood that's sitting around in its relatively low oxygen concentrations. It'll start giving off this 2,3-DPG, and it'll actually lose affinity and makes it harder to saturate. So we want to get to 100 millimeters of mercury of oxygen, regardless of our situations. Well, we're not always at sea level. Sometimes we're flying in planes, and sometimes we're climbing mountains, and sometimes we're underwater. And so the partial pressure of oxygen will change. So at sea level, it's around 160. 21% of 760 is equal to 160. And you're breathing, and as it goes into the alveolus, it drops down because of the dead airspace to around 100, but you still saturate your hemoglobin. It's no problem. Let's say we're at 5280, which is the sea level, the height of Denver. Now the ambient pressure, it's still 21% there, oxygen, but the ambient pressure has diminished. And so you're breathing in 130, which means that you're probably going to be a little bit under 100 by the time it reaches the alveolus, which is not fully saturating that hemoglobin. Now, over time, your body will acclimatize to that. It'll make more red blood cells, and you'll have more hemoglobin. So people at elevation tend to have higher hematocrits, which means they have higher oxygen carrying capacity, even though that those red blood cells are not fully saturated. Now, at the top of Mount Everest, the ambient pressure is only 300. And so 21% of 300 is about 42, which is way below saturating. In fact, this is almost the same as deoxygenated blood. Very, very low. Well, how do we survive that? In fact, the top of the Mount Everest, anything above 26,000 feet is considered the death zone, because you can't survive up there for more than a few days without oxygen. So what do? You breathe a little additional oxygen. So right now you're getting about 42. All you would need to do is get to about 50% oxygen. All right. So if you got to 50% oxygen, that would be 150. All right. So 50% of 300 millimeters of mercury would be 150. It would be almost as if you were at sea level. And that's the secret. That's why you don't have to breathe pure oxygen. What you have to do is breathe enough oxygen concentration in order to get that partial pressure around 160 or so. Obviously, between 160 and 130 is going to be okay, but closer to 160 better to saturate those red blood cells. That's the power of Dalton's law. That's the power of Dalton's law. You can calculate what percentage of oxygen you need in order to get blood saturating conditions. So a little break here, a little humor for you. I don't have time to jog or lift weights. If it weren't for smoking, my lungs wouldn't get any exercise at all. This is definitely when we're not understanding the concept. So if you've had a little trouble getting through the material that I just showed you, by all means, ask a question. Let me know. Do the practice question. See how well you get it. The more you get it, the more powerful you will be in whatever part of healthcare that you're in. Now, here we have some terms to describe some of the issues when we depart from normal function. If we stop breathing, all right, no ventilation, this is known as apnea. We often talk about sleep apnea as something that people often have to deal with. Or maybe we're breathing too much, hyperventilating. We call this hyperpnea, increased rate of breathing. You don't have to be truly hyperventilating, but if you're anything up above, let's say 18 or 20 breaths per minute, you're qualifying as having hyperpnea. Dyspnea, this is where we have unusual breathing patterns. Shane Stokes type patterns or situational problems like choking and so forth is what we call an acute dyspnea situation, where we have abnormal breathing patterns or you're having some issue with moving air. If you don't have enough oxygen, what we get is called hypoxia. So when we were talking about altitude in the previous slide, that situation when you're at the top of Mount Everest is known as hypoxic hypoxia. You can have anemic hypoxia, you can have toxic hypoxia, like for instance being exposed to cyanide gas. You can have circulatory types of hypoxia, where you're not getting enough oxygen to meet metabolic need. Now, if you are not supplying enough oxygen to the blood, a condition that can occur is called hypoxemia, where the blood's flowing just fine, it's just that it is perpetually undersaturated. So hypoxemia is low blood oxygen, and there are reasons why that might be. Choking would be an example of, or being at high altitude, that sort of a thing. Poor lack of blood circulation, myocardial infarction. It's not the same as lack of perfusion. You can have lack of perfusion that leads to a hypoxic effect. Hypoxemia means low blood oxygen for whatever reason. So in any case, what we have is inadequate oxygen to meet metabolic need. And it often manifests as this cyanotic condition. The skin no longer has the bright red blood flowing through its capillaries, and you take on a decided pallor. Sometimes it can be a sort of I don't want to say green, but they do have a pallor to them, especially if they have melanotic skin. Folks that are relatively pale in complexion, they will look quite blue. And if we have enough oxygen to threaten life, we call that asphyxiation. So if you have death by asphyxiation, it is due to excessive hypoxic, where the tissues in the brain, the heart die because of lack of oxygen or inability to breathe. Now, carbon dioxide transport is a little more complicated. There's a little more chemistry going on, but we're going to try to abbreviate that a little bit. Let's look at this picture right here on the right. When we have CO2, it will react with water to form carbonic acid, and will give off a proton. And guess what? That proton is given off somewhere around pH of 7.4. That's why our blood pH is around 7.35 to 7.45. So when I ask you in class, is CO2 good or bad? I would tell you that CO2 is just as important to life as oxygen, just for different reasons. CO2 and the management of CO2 is super important for blood pH. Now, most of your CO2 is carried in the blood plasma as this ion right here, this HCO3 minus. It's a -1 charge. And that is known as the bicarbonate ion. And here it's listing 85%. I see that number a little bit anywhere from 75 or so to 85%. It's a lot. It's a big, big chunk. It's the vast majority of CO2 is carried in this form. And when we get to the alveolus, what happens is you have low CO2 here. So the blood CO2 moves into the alveolus, and the CO2 inside the blood moves into inside the blood cell, moves into the blood plasma, and then you begin switching this reaction back to CO2 and H2O. It's called the law of mass action, and I teach it in my advanced physiology courses. So that as CO2 lowers here, we start converting it back from the blood plasma from bicarbonate. And the opposite is true in the tissues. We have elevated CO2, it moves in, and we convert it to bicarbonate, of which about 85%. Now, some of that CO2 will bind weakly to hemoglobin. That's what HB stands for. And again, that number varies. It can be as little as 5% up to about maybe not quite a quarter. It varies. And we call that that molecule that has CO2 bound to it, that hemoglobin with CO2, it has a name called carbaminohemoglobin. All right. And then about a small percentage, about 10%, is resident in the blood plasma. But it will diminish when we get to the alveolus because the alveolus is low in CO2, and that creates a gap here, and we get this sort of progression like this. Kind of like the tide flowing in, tide flowing out. We've got high CO2, tide flows in. We've got low CO2, tide flows out. And it's super important for helping regulate blood pH. And just as important as to life in just in a different way as oxygen. Now, how we get that HCO3 in and out is this funky little thing. I think this is a little bit of trivia, but it's kind of nice to know. We have this exchange protein that when we bring HCO3 in, it moves chloride out. And when we send HCO3 out, it pulls chloride in. And that's why it's called the chloride shift. So out in the blood tissues, what you see is blood chloride concentrations dropping. And when you get to the lungs, you see blood chloride increasing, and that's due to that chloride shift. We're kicking out HCO3, bicarbonate, taking in chloride. Over here, we're taking in bicarbonate due to the loss of CO2 and exchanging it for chloride. So it's called chloride shift. The main problems that we see most of the time with breathing and moving air and gas exchange has to do with conditions of the lungs. We call it COPD, secondary to smoking, or they have asthma. They could have pulmonary fibrosis. They could have silicosis if they're coal miners. That is just making a raging comeback. Why? Because the coal seams are getting less and less productive. And so the coal machines are cutting more and more non-coal stone, which means more silicon in the air, and they're getting silicosis, which leads to a condition like this, emphysema. So when we look on an x-ray, here's a normal lung. One of the things you'll see is it looks like these lungs are bigger, right? We call that hyperinflation. The reason that it happens is that you're losing alveolar surface area. The emphysema is fundamentally a breaking down of the alveolar sacs. And so there's less surface area. And so we get this sort of flattening diaphragm hyperinflation looking situation relative to a normal lung. The heart is a little bit silhouetted in here. You can see there's a little bit less prominent profile here. It is on the left versus the right. The enlarged lungs are actually pushing the heart downward due to their expanded volume. And we have reduced lung markings. You can see some of the bronchi in here down to about the third or the fourth division, and you can see those are reduced because again, lung tissue is being destroyed. It's becoming more stiff, and so it's just not showing up in the X-ray. In some cases, you might even see air pockets. I don't see any in here where you have complete destruction of the tissue, leading to absolute loss of tissue at all and loss of opacity. Last thing, and this is the most obvious, so you don't need an X-ray to see this. It's the barrel chest. Why? Because more often the person with COPD and we're talking mostly about smokers is having to use ancillary muscles in order to move air. The lungs are less flexible, they are less compliant, less elastic, and so it requires more use of these intercostal and accessory muscles to breathe. More of that they're trying to move air up out of their lungs, which means they're using their abdominals and their ancillary muscles and their diaphragm to try to expectorate material out of the lungs. And so they do get this barrel chest. Now this guy looks like he's kind of buff to me. It's a little bit of a flattering barrel chest. These guys, it literally is, you don't shrink down at the waist like somebody that's actually in really good shape. They tend to look like they're just one big barrel. Here in these two images, this patient has a normal right lung and then a little bit of a problem down here in the left lung, whereas this patient is much more severe. These are areas of infiltration. That is to say, there is fluid buildup. It could be pus, it could be blood, it could be just interstitial fluid in the case of an inflamed lung. These are all hallmarks of severe acute respiratory syndrome, or SARS. It can be a viral cause. It can be due to injury, like for instance trauma, you name it. So severe acute respiratory syndrome. Now, the virus that we know of as COVID created a SARS condition, severe acute respiratory syndrome, COV, coronavirus 2. They even would put a year in front of it, depending on the year that it was identified, but it was formally named SARS-CoV-2 because the severe COVID infections created a hyperinfiltration in the lungs, leading to basically hypoxemia and asphyxiation. Moving on now into breathing mechanics, obviously we inspire, bringing gas in, and we expire, ventilating gas out. So we're going to deal with Boyle's law and some of the mechanics of ventilation. Now, in the cell, we have another form of respiration, and this is the creation of ATP, glycolysis, oxidizing pyruvate to make acetyl-CoA, Krebs cycle, also known as the citric acid cycle, and electron transport. So this is cellular respiration, and this is the reason why we ventilate. And that's why we generally call the mechanics of breathing ventilation and not respirations. There is some crosstalk. People talk about it that way. But respiration in our physiologic world is the metabolism of glucose or acetyl-CoA in order to make ATP. A few abbreviations and things for pressures. Remember that atmospheric pressure, that's the pressure outside the body. At sea level, that's normally around 760 millimeters of mercury, or 1 atmosphere. So PATM is the atmospheric pressure. Then we have the intrapulmonary pressure, or sometimes they refer to it as alveolar pressure, PPUL, all right? That's going to be, should be very similar to the P atmosphere. If these are dissimilar, that implies that there's some problem with conductivity between the lungs and the atmosphere. So for instance, if we have COPD, we might have a difference in P pole versus P atmosphere. Then we have intrapleural pressure. It's the space in between the lungs and the chest wall. Intrapleural pressure is a few millimeters of mercury less than what either the lung is or the atmosphere. If these are supposed to be very similar, let's say it's 760, then we have about a 4 millimeter mercury difference, and that keeps the lung in positive contact with the chest wall. All right. Keeps it in positive contact, prevents collapse. That transpulmonary pressure there should be a difference there enough to keep that lung inflated. And if not, there's a very severe risk of a pneumothorax, is what we call it. The thorax should be closed. That's what makes chest wounds so incredibly dangerous. The thing about a chest wound is that it will allow equilibration of the transpulmonary pressure. All right. You essentially achieve atmospheric pressure outside the lungs, but inside the chest, and now the lungs will collapse. So the thorax should be a closed container. I'm going to give you the concepts and then let you work through this chart down here. Some people like these charts. It doesn't really work for me that well, so I'm just going to tell you what goes on. So what happens is, under normal, what we call tidal volume breathing, just normal diaphragmatic breathing, this guy contracts, the volume increases inside the chest. And since the thorax is essentially closed, you have a given amount of gas in here. And if you increase volume, the pressure drops. Well, we have these airways, and that allows gas to come into the lungs. Now, when we relax the diaphragm, it rises. We now are reducing the volume of the lungs, and the gas in there is going to have a higher pressure, and it will move out to the area of lower pressure in the atmosphere. So we change volume, that causes a change in pressure, and the atmosphere equilibrates. Change volume, change pressure, atmosphere equilibrates. That's Boyle's law, that as you increase volume, pressure decreases. As you decrease volume, pressure increases for a given amount of gas. Here we are showing it a slightly different way. So here is the pressure outside in the lungs, all right? That's inside, that's the alveolar pressure. Here is the transpulmonary pressure. That's that space in between the lungs and the chest wall. And you can see 1, 2, 3, 4. It's about 4 millimeters of mercury lower. And it mimics the tidal volume, if you will, of breathing. As we decrease pressure, we get an increase in volume. As we increase pressure, decrease. That's why it's inverse. All right. Now, airflow should equilibrate and not equilibrate with difficulty. If we see a change in difficulty, that's often due to what we call increased resistance, reduction in diameter, or occlusion of some kind. Other things that can affect airflow, the amount of surfactant. If you lack surfactant, like for instance a premature baby, or very, very elderly people also experience loss of surfactant secretion. And that can cause the lungs to not be able to conduct air in and out of them as well. Compliance, the compliance of the chest wall. If the chest wall is very, very stiff, or if you have a lot of scar tissue, what we call fibrosis, you'll have reduced compliance. If you have something like emphysema, you might experience reduced compliance, and you also can't return back to the original volume once you've expanded it. It takes more force to expand, so there's less compliance, and the lung refuses to return back to its original volume. That's a loss of elastance. Elastic recoil is just the mechanism behind elastance. Breathing is a little bit of a funny thing. You can actually control breathing voluntarily through your intercostal muscles and your accessory muscles. But under most situations, and your diaphragm as well, I guess, under most situations, you're not thinking about breathing and you're really only solely relying on involuntary contractions and relaxations of the diaphragm. And these motions are both regulated. So you have voluntary control and you also have this involuntary control. Well, the center of involuntary control is called the pneumotaxic center in the pons, if you will, of the brainstem, and as well as some medullary areas as well. All right. They are monitoring blood chemistry. They are also tasked with sending impulses out the motor neurons to affect breathing. So yes, you can control voluntarily through higher brain centers. All right. Involuntarily, you have chemoreceptors, and there are actually two of them. There's one that senses oxygen, which is actually in mammals less important. It's the least important of the two. And then the other one senses carbon dioxide. If you want to test this out, just breathe all the way out. All the way out there. You hold it. You hold that out there pretty soon, within 10 or 15 seconds at most, you'll start getting a very, very serious desire to breathe. If you exhale as far as you can, you're rapidly increasing the CO2 concentrations in your lungs. And that increases the CO2 in the blood and kicks in that CO2 drive. And so that gives you that urgency to breathe. Now, folks that are chronic smokers, folks that have COPD, they have issues because that CO2 drive gets knocked out and they're relying on oxygen instead, which is why you never give high flow oxygen to an unconscious patient without direct supervision, because if they have COPD, that increase in oxygen will cause them to stop breathing, which is not good. There are other reflexes in here, muscle and joint reflexes that can also trigger changes in breathing rate. Normal rate somewhere around 10, 15 or so. The main nerve here is called the phrenic nerve. It goes to the diaphragm. It's usually cervical nerve number 4. As I mentioned in the previous slide, CO2 is the primary driver. Acidity also is there too, but it's really about the CO2. These guys are what drive the desire to breathe. If you have hiccups, a very, very easy way to get rid of the hiccups is to exhale and hold it, and then just barely bring in just enough air to keep you from just bring it in super duper slow. That'll cure the hiccups right away, because hiccups are normally triggered by hyperventilation. Laughing, sometimes eating will do it too. You're hyperventilating while you're eating, and that will trigger hiccups as well. Hiccups are there to interrupt that hyperventilation. All right. You also have an oxygen drive. It's a little bit weaker. It requires a little more severe condition, less than 60 millimeters of mercury. Again, these things are found in the pons area. They monitor in the aorta, and so in the hypothalamus. And so they're looking at these levels of CO2 and oxygen. Again, CO2 and pH is the strongest one. If you have somebody that has COPD, they will be more reliant on this O2 situation. We assess lung capability indirectly by looking at volumes, and you can describe things as restrictive or obstructive and so forth. These volumes are achieved by a technique called spirometry, where you are measuring the volume of inhalation and exhalation under different conditions. Basically, the ones that you're going to want to know are here boxed in blue. Your normal diaphragmatic at-rest breathing is known as tidal volume, and it's about 500 millimeters, about half a liter. All right. Tidal, that's all you need when you're at rest. It's just a steady 500 milliliters per cycle, and that's called tidal volume. If you breathe in deeper than that, you can breathe into, a couple of liters more, That's called inspiratory reserve volume. And anything below normal tidal volume that you breathe out is called expiratory reserve volume. And you do hit a limit here. You can see that's a little more than a liter out beyond normal tidal volume. What's left over is the volume occupied by tissues, fluids, and so forth, dead air. That's known as residual volume. And that's the main thing. When we add two or more volumes together, we call them capacities. All right. But the primary ones you're going to want to know are here in this boxed area. And not only do we have overall volumes, it's how much of the volume you can move in a given period of time. You may be a pair of legs with lungs, like a professional cyclist, and have huge capacity. But if you can't move it, you'll have problems. That's why we call obstructive disorder or restrictive disorder. Under a normal person can exhale a given percentage of their overall volume in 1 second, the forced expiratory volume. So not only can you measure overall volumes like tidal volume or inspiratory capacity and so forth, you can also measure volume over time, and usually it's expressed as a percentage. So your normal FEV for 1 second, forced expiratory volume, you're breathing out, is about 80% of that volume that you can take in. So you breathe in all the way in, and then you force it out, and about 80% of that can get out in 1 second, with the rest occurring over the next 2 seconds or so. Generally, by the time you get to 3 or 4, you've gotten it all out. If you have less than 80%, that means that you have some issue with moving air, and that's what we call obstructive disease. Something's in the way. You're choking. You've got a severe acute obstructive disease. You've got fibrosis of the airways, that sort of a thing. Inflammation, asthma, and so forth. Obstructive. Your FEVs decline, and so it flattens out. So what you do is you compare FEV1s and sometimes more than that. Look at a table for your typical normal values and determine if somebody has an obstructive disorder. So what constitutes the difference between obstructive, which we just talked about, a reduced FEV, versus restrictive? Now, this graph is a little confusing because it's adding an additional element here. And so I'm just going to gray this out here for now. Let's just focus on this area right here. You can see this patient that has obstructive disorder has a little bit of a diminishment in overall volume, but that's not the important point. The important point with destructive or obstructive disorder is that you have a reduced FEV. You have a reduced FEV. Restrictive, on the other hand, FEVs may be normal, but your overall volume has diminished. Over here on the right, the overall volume is increased. It's just that there's a bigger fraction of residual volume. Okay, so overall volume is actually increased, but your FEV has decreased in that context of increased volume. Over here on the left, you can see that overall volume has decreased. And so the FEV1 may be normal from a percentage standpoint, but it has diminished because the overall volume has diminished. There is no way you can achieve a normal volume with restrictive disorder, no matter how well you move the air. I think this graph shows it better, in that here's your normal lung, and you can see about 80% in FEV1 of the total volume can be expired by forced expiration. Now, this patient has a significant COPD deficit of some kind, obstructive deficit. They're only moving about 20% of the air in that first second. And even then, it takes several seconds for them to finally achieve that max volume. You can see that they can still get there. It's just that it takes so long that what can happen is that that reduced ability to move the air means higher CO2 in the alveolus and lower O2, because you're just not moving enough air to replenish the oxygen or diminish the CO2. So this is a pretty significant pathological situation, obstructive. Normally it would be a little bit higher for somebody with mild or moderate obstructive disorder. Restrictive, on the other hand, they might have perfectly fine FEVs, 80% of the max volume, all right, but they never can achieve the volume. These people may be just fine at tidal volume situations, but they may become exercise resistant. They have exercise intolerance because they can't increase their volume to meet the metabolic need under increased metabolic demand of exercise. So I think this curve shows that a little bit better. Slower ability to reach an otherwise normal volume leads to higher CO2s, lower O2s in the alveolus. Here, we can never compensate for an increased metabolic need. We might be fine at rest. As soon as we start moving and grooving, that may be a real problem. Just to wrap up here, I haven't emphasized the numbers in this presentation, but you can actually go and look these up. I think that's fairly straightforward. You can calculate total lung capacity based on these, and basically what you're sort of doing is just doing a little bit of arithmetic. So just have a go at it. You can calculate vital capacity based on the following volumes. All right. You can calculate the tidal volume if you have the capacities and so forth. So go back to the chart, crunch a few numbers here and there. These were inserted by the course coordinators, which means that these kinds of problems may be likely when we get on to either the quizzes or the exams. You've got, yeah, this one. So all these future clinicians, rapid pulse, sweating, shallow breathing, according to the computer. This is why we shouldn't always rely, especially on now that more and more people are relying on it. We need to have the appropriate, at least the appropriate background, not only so that we know certain things, but more importantly, we know how to ask the right questions in order to get effective information from the computer. All right. The computer doesn't assess context. So what you do is, by having some background knowledge, you can then impart context on your queries to the computer, which will then more likely to give you accurate results. That completes our lecture today. Thank you for your time. As always, bring your questions, and I look forward to seeing you in class. Take care.